want to echo that. Thank you, Dr. Tweedy, for being here. Before I give a brief introduction of you, I wanted to have Dr. Finn say a few words.
Thank you so much. I'm Patricia Finn. I'm the chair of medicine. It's really a deep honor to welcome Dr. Tweedy. My role here is very simple. It's to honor one of those that went before us, and that would be Dr. Richard Weber, who is a alumnus who really completely is committed to the next generation education, finding our replacements, and really thinking about how we can provide exceptional care for all. So with that spirit, I'm happy to now turn this back over to Alana and to warmly welcome Dr. Tweedy and to thank Dr. Weber yet again.
Thank you, Dr. Finn. I'm really excited about introducing our speaker today. I saw him speak a few years ago and also read his book too. And he was a phenomenal speaker then. I know he's going to leave us in awe today as well. No pressure at all. But Dr. Tweedy is an associate professor of psychiatry at the Duke University School of Medicine and the staff psychiatrist within the Durham VA healthcare system. He completed both medical school and his specialty training at Duke. Within the VA system, he directs a team of mental health providers working in primary care clinics, and at the medical school, he leads a behavioral health seminar for second-year medical students and is a small group leader for another course that introduces these students to advanced aspects of the patient-doctor relationship. Dr. Tweedy has written extensively about the intersection of race and medicine, both in academic journals and in popular print publications. His 2015 book, Black Man in a White Coat, A Doctor's Reflection on Race and Medicine, made the New York Times bestseller list and was selected by the Time magazine as a top nonfiction book that year. Without further ado, I'd like to introduce Dr. Tweedy, and thank you again for being here today.
Yes, thank you. It's a pleasure. I just want to thank everyone involved here with inviting me and making all this happen. Why don't we, so today, we'll be talking about race in medicine, and obviously race has sort of hit our national conscious in a very heavy way at the last few months. Can we start with the first slide? Yeah, so 2020, right? So it's just been some kind of year. It's certainly a year that all of us will remember for long thereafter. There's COVID-19, right? And what COVID-19, and one of the stories that sort of come out of that more recently is just, the last few months is how COVID-19 has impacted Black and brown communities disproportionately. That's one very real story. And that's a story that's been built on a historical story that I'm going to kind of go into in a little bit more depth from here. The second part is just the last month or two, all the nationwide protests, really galvanized by the George Floyd killing, the murder. But there's so many others. Again, that was also built on a larger history and story as well. And so all those things have sort of come together in this moment in time in which we've had so much going on. And I wanted to just sort of take a little bit of time to reflect on medicine and kind of where's medicine's role kind of within this and its history, and kind of how do we move forward from some of these things. So yeah, the next slide. Yeah, so it's 2020 this year, but these things have been set in motion long ago. This quote from James Baldwin I think is very instructive when he says, "They will not go away because we pretend that they are not there." And he was referring to the racial problems of the day and all the challenges that attended it, and the sense that people that if we just kind of don't talk about it, or we just sort of ignore it, or just don't stop talking about race, then somehow these problems can be solved. And so we see where that's gotten us, obviously. And so Baldwin was reflecting on that many years ago. Can we move to the next slide, please? So Baldwin and other writers have described our history with race in the language of medicine. This idea of the race relations in our country being a poorly healing wound, or virus, or that's unchecked, or cancer that recurs and kind of destroys us from within. And you can just sort of think about what's happened in the last few months, and also what that's built upon, and how all those things just have sort of been there in place and are sort of reactivating in a very, very difficult way in these last few months. Let's see the next slide, please. So talking about race is always a challenge. At least and it still is. And there's books written about that, about the challenge of talking about race. And we think about it in its most core way. It's very divisive in the sense that, as one writer put it, each side's grievance fuels the other's resentment. So you can just sort of think about how that is. So if a white person has a grievance about how, for instance, affirmative action is, quote, reverse racism or something, and then you can sort of see the resentment that might engender among a black person. And then if a black person says something about a white person, there's a sense, oh no, I'm not racist, I'm colorblind. And so there's that, it's like the one person's grievance fuels the other's resentment. So it can be really difficult to have rational conversations about this topic. It's also limiting, and we'll get into that as well. This idea of when we say these terms, white, black, it's so, this is where we are from a sociological standpoint, but from a larger sense, it's very limited in terms of who we categorize and what do those labels mean. And maybe later on we'll get into a more broad discussion about that, because one of the concerns I have with medicine is when we talk about race as a biological factor, again, what does that mean? And so we'll cover that a little bit more. So let's go to the next slide, please. So honing a little bit more into this idea of race in medicine, there's this quote from Dr. King, is well known. It was uttered in Chicago. He was visiting I think it was the physicians, I forgot the term now. I forgot the organization, but I'm totally blank on it now. But it was one of the social activist physician groups of the time, and they were meeting in Chicago in 1966. And Dr. King was quoted during that for an AP interview when he said, "Of all the forms of inequality, injustice in health is the most shocking and the most inhuman, because it often results in physical death." So that sort of speaks for itself, but the next slide will put some numbers to that. So can we show the next slide? So this is what it was like around the time Dr. King was making those statements. So this is just two states. I could have picked any others, but when you think about Dr. King, you often think about his early life in Georgia, his later work in Alabama, Montgomery boycotts and Selma and those sort of things, and being born in Atlanta and going to college there. So you think about those two states often when you think about Dr. King. But look at the disparities there in life expectancy around the time, around 1960. You see, basically in Alabama and Georgia, it's basically a decade difference between white women and black women. And among white men and black men, it's about 7 years. So the reason why maybe it's more with women than men, some people think that was due to issues around maternal mortality, which of course is still an issue that we're dealing with a lot, even in our modern times. And so that just sort of gives you a really stark difference between the real life and death aspects of race. Next slide, please. Race also, of course, at that time occurred in a much broader context beyond just the world of medicine. So here we have images that are they're infamous, but they've all been, sometimes it's worth just sort of taking a look at where we've come and what our context is. So the top pictures, is of a young woman trying to desegregate a school and being yelled and heckled at, as she is there. And then of course there are all these signs and pickets about how we don't want race mixing, if you will. And then on the right side of your screen, all the sort of literal vestiges of separate but unequal in terms of, different restrooms and seating and all those sorts of things. So that was sort of the context, obviously, at that time. So can you next slide? So also during that same time, when there was all that tremendous sort of white resistance, there were many people who were really trying to change things, right? So some of these images will be familiar to people, some of you, some may not. This is really important. So there's, Thurgood Marshall on the top left, and then there's the two women in the middle is Fannie Lou Hamer, involved in the Mississippi voter registration, the 60s. There's Shirley Chisholm. Then on the right, the top right, there's Medgar Evers. So these are all really famous, important people historically involved in the civil rights struggle. Too often, that history gets relegated to just Dr. King and Rosa Parks, and it's much, much broader. And there's people that really need to have their share say. On the lower panel, there are actually some prominent black physicians. Who often really get lost in that historical discussion. So the bottom left is oh gosh, I can't remember back on his name now. He was the president of the NMA. Gosh, I'll come back to that name. I can't remember his name for some reason right now. He was the president of the NMA when they were working to challenge the AMA with the whole issues of desegregate of how medical boards and medical societies were segregated, and trying to get doctors hospital privileges and things of that nature. So he was a really important piece. The man in the lower middle is actually, that's the one standing up. It's hard to see in the photo, is Dr. Charles Drew. He's standing there giving, talking to a group of students at Howard Medical School. And so it's a really, and Dr. Drew was just a tremendously interesting person in that he was a lot of things that we use in medicine in terms of blood storage. He was one of the first sort of pioneers in how to store blood and use it for transfusions in the battlefield of World War II. But at the same time, he left the Red Cross because they still had racially segregated blood at the time. And then he went back to Howard and became an instructor there. The man on the bottom right is Chester Pierce, who's a psychiatrist. And he actually coined that term that we hear called microaggressions. He was the person who sort of first coined that term. So these are all people who were fighting the battle during that time. What's interesting and what I think is missing and historically is that, you notice all the faces there are African-American people, but of course there are many white Americans who are really involved as well. And I think it's like a missed opportunity historically when we spend so much time sort of defending Confederate statues and Confederate monuments and people who do that, when there's plenty of white people historically that could be put in place to, as an alternative to those current statues who really did great things to advance the cause of history. But they're often been lost to history. And to me, that's a missed opportunity in terms of how we define our country and our narrative if we sort of are stuck on this debate about, Confederate generals and things like that. Next slide, please. So, of course, the world of medicine was undoubtedly influenced by that larger world of Jim Crow. And so this is, the most famous or infamous way in which that occurred was the Tuskegee syphilis experiment, which took place from 1932 until 1972, just a couple years before I was born. So that's when the U.S. government was basically, Public Health Service was, for those who don't know, funding the study of untreated syphilis in African-American men, not letting them know that not telling them they had syphilis or they had an infectious disease, also never notifying them that, there was a treatment, right? Penicillin came aboard in the late 1940s. So for a period of 20-something years, and you go back and look at the medical journals, there's actually medical journal articles written about this study. And it's just an unbelievable that this, well, not unbelievable, but it's a testament of the times that they could write about this study in such an open way. It wasn't like it was a secret, in an open way, and not feel like there was some moral problem with that. That is sort of very much a testament of the times. The book Bad Blood is a book from the early 80s, which sort of really documents that historical period quite well. Next slide, please. So that was one side of history. But this is important for us to think about our current times. There's always people on the other side as well. So there were people during that same period. So while some doctors were, experimenting on African Americans without their awareness, there were other white physicians, doctors, and nurses who were there fighting the struggle, and they were down in the South, and they were providing care. So this is the Medical Committee of Human Rights. That's actually the organization that Dr. King spoke to back in the 60s. But the Medical Committee on Human Rights, they took people down to the South during that era of the marches, and they provided medical care to the people there. And they could see the stark disparities, but they were sort of providing care in the moment, like for people as they were protesting and various things like the Selma and places like that, and also just sort of helping to set up clinics and things to help bridge that larger divide. So if the link here, there's actually a video someone can pull up, and it's like a 5-minute video, and it talks about that. And so they circle that particular woman. I'm not sure if she's a doctor or a nurse, but it's just the important piece. She was involved in the Selma March as well. The infamous Selma March over Edmund Pettus Bridge. So I think it's important when we think about our history that there's always these two sides. There are doctors on one side who are doing their sort of ghastly experiments, and then there were doctors on the other side fighting that fight for equality. Next slide, please. So my journey with all this stuff came many years after that, right? So those slides I was showing you were from dating for the 60s and early 70s. So I started med school at Duke in 96. So 25 years after that, 30 years after Dr. King's famous statements about the inequality of in health. You could go to the next slide, please. So when I started at Duke in medical, as a first-year medical student, my hope was that medicine was somehow kind of I hate to use that word post-racial because we clearly that's not the case, but there was a sense that, you know, there were opportunities there, and that the worst was behind us. I guess that's probably the best way to put it. And that the part of the appeal of science and medicine was that it was concrete and objective, and that it was, you know, it wasn't like you know, history or you know, business or law where things could be much more subjective. So, like, you know, it's concrete, right? These are scientific details and mathematical details. And so that was part of the appeal to me for medicine, to be honest with you. Well, as I got to medical school, I learned pretty quickly that, you know, race was certainly talked about, but it was talked about in ways that seemed very problematic to me. And I'll get into that a little bit more in the beginning, a little bit later. But I would say the first concern was that every time we had a lecture, you know, you would just discuss the biology and the chemistry, the pathophysiology of disease, but they would always dovetail in the end to this discussion of demographics and who was affected more. And it would always be this sort of narrative that blacks had every disease worse, and if it wasn't more common among blacks, then it was even worse. So it's either more common among blacks or it was worse if blacks got the disorder, or often both, right? So you think about high blood pressure, heart disease, kidney disease, you name it, diabetes. And so there's a narrative over and over again, but there was no sort of context applied to it. And further for me, it had a real personal meaning. As you can see in the slide here, this is a slide of my grandmother, my maternal grandmother, who grew up in that part of Virginia in the same setting where that Henrietta Lacks book was set, you know, where The Mortal Life of Henrietta Lacks. She grew up in that same period of time, you know, about 5 miles away. And she was my first sort of sense of the idea that their health system may not be fully equal, or at least people's perception of it was troubling. I remember growing up and we'd go visit her and she had high blood pressure, and she would say, I don't know about these doctors. I don't know if I trust them. You know, maybe they're trying to just keep me sick so they can keep making money. There was just that sort of like just that sense that maybe a doctor wasn't as benign as, you know, you might see on a television show or something like that at the time. So what happened with her case is that she had high blood pressure for many years. And then as I got older, around the time of college, she had a stroke. And that first stroke she was able to kind of bounce back from, but the next stroke was one that was more serious, and she was never the same at that point forward. And then during my first year of medical school, as I was learning about all these different medical disorders, right, I got the news that you know, she had developed severe heart failure. And within a short time after that, she passed away during my first year of medical school, right during my first day of gross anatomy lab. And so you think about, you know, high blood pressure, stroke, and heart failure, they're much more common among African Americans, and they have a worse course as a result. The next slide, please. So for me, this also had a very personal dimension. This is me around the time as a first-year medical student. As I always say when I joke, I looked long and hard for a nice, sunny picture of me around that time in my life, and this is the best I could come up with. So that speaks its own volumes about that period of time. But around that time as a first-year medical student, toward the end of that year, we began to sort of do clinical skills, practice blood pressure, you know, taking vitals, drawing blood, putting in IVs. And during one of these sessions, I got a classmate measured my blood pressure, and it was quite high. And then she rechecked it, and it was, you know, it was still elevated. And the faculty member came in, rechecked it, confirmed it. You know, maybe a few days later, a week or so later, I went to the student health clinic. They confirmed the elevated blood pressure. They did some labs. They found I had some urine, protein in the urine as well. So you know, which can be a sign of kidney disease. So you had high blood pressure. You had early signs of kidney disease. I'm 22, 23 years old. I've been a college athlete. I've been physically healthy, at least I thought I was. And so this really struck me like a ton of bricks, because it was a sense that maybe there was something, you know, why was I experiencing these problems as well at such a young age that I was learning about in the classroom. So the classroom conversation became something that had even a much more personal dimension to me not only for my larger community, but also just for me as an individual and my own family and any future generations. Next slide, please. So the problem with medical education is two things. So this is the issue. So when I was taught about high blood pressure or any of these other diseases, the obvious question is why? Why are these disparities playing out the way they do? And why are African-American people disproportionately affected? Right? So that's the obvious question is why. So what happens is that historically, if you don't talk about the fuller context, you will invite, if you will, more racist or ignorant theories to fill that gap or fill that void. And so one of them is this idea of race as fundamental, biological difference, right? Just that Black people are fundamentally different in some physical way, and that thus explains that you're just destined to have sickness and be sick. And it's almost like nothing we can do about it, but then just treat the aftermath. And I remember I had talked to a professor one time, and I was asking her after had high blood pressure or had been diagnosed with high blood pressure, and she was like, "Well, I think it's just genetic, and that's just the way it is. And the best bet you can do is just take medicine the rest of your life." And I was like, man, that was the end of the story. So the picture I show here, the thing is actually of an author of a study that came out in 2016, which looked at this idea and what do doctors believe about biological differences. And so this was taking place at the University of Virginia, this survey, and it looked at first and second year medical students as well as more senior medical students and junior residents. And it was looking at this idea of asking people various questions, and the upshot was that there was many of the students had beliefs that Black people were physically different, like their skin was thicker or their nerve endings weren't as sensitive. And so the whole connection for this article was about how that might then impact how you assess pain or treat pain. And so of course, there's a well-known literature that African Americans are less likely to be treated with the same level of medication. And so one theory could be that some doctors are subscribing to this idea of biological difference. The other way in which these things come into play is this idea of race as a behavioral, quote, behavioral pathology, this idea of like culture, and that Black people are sort of just making bad decision after bad decision, and then that's impacting their, just willfully, and then that's the reason why the health problems are the way they are. This photo is of a recent Ohio congressman, not congressman, but like a state representative who's also a physician, I believe, and he made a comment in a public forum speculating about COVID and why were the rates higher among Black people with COVID. And why were the death rates higher? Why were the infection rates higher? And one of his comments was, maybe Black people don't do as good a job washing their hands. And so, again, that idea of like somehow we're doing something wrong, and that's why things are what they are, without any other context. So what's missing? Next slide, please. So what's missing, obviously, is this whole what's called the social determinants of health. Now, certainly medical centers and medical schools have made efforts, in hospitals have made efforts to talk more about these things as time has moved forward, but those other elements still remain in a very problematic way. So certainly we talk about race and health insurance and how the differences in care you can receive if you don't have health insurance or you do, if you have Medicaid or if you have private insurance. These are very real tiered systems that play out. In my field in psychiatry, which I'll talk a little bit more, they're actually just even worse than in the other areas of medicine. But then, of course, there's all the other issues of where people live, where they go to school, the neighborhoods they live in, and how all that impacts health. That's a much more fuller understanding of what's actually on the ground and causing a lot of most of these differences and disparities that we're seeing. Medical education is beginning to talk about these things. One of the challenges, though, is that if you have a lecture, a half-hour lecture, or half-day lecture at 4 years of medical school, and then the student then goes out into the wards and spends 6 months in a setting where the doctors don't believe this and they believe something very different, you can sort of see how that informal curriculum can still overwhelm this earlier education that our students often receive. So when we talk about changes, we got to really think about how we're even educating doctors moving forward. Next slide, please. So psychiatry, yes. So psychiatry is really dramatic. It's even in some ways worse than the rest of medicine. You certainly see it play out where African Americans are, as I mentioned in the slide here, when African Americans receive care, it's much more likely to be in an emergency room setting, more likely to be involuntarily treated. So that involves law enforcement, less likely to receive outpatient care, psychotherapy, the things that are sort of more the foundations of preventative kind of care, and much more likely to be seen in the sort of in the more back-end traumatic way. There's a story I tell briefly in the book working as a young resident in psych ER, and two women come in back to back with very similar kind of clinical situations, but one doesn't have insurance and one does. And so the one that has insurance goes to the private facility. Again, nobody wants to be in a psych facility that's locked, but it's certainly there's some that are way better than others. The other person doesn't have insurance, has to go to a state facility. And the complication with going to a state facility is that you had to bring law enforcement on board. So this person then had to be sort of put into like an orange jumpsuit and handcuffed and all these other sorts of things and put in the back of a police car. So imagine that that's your first encounter with the healthcare system. You come in for seeking help for distress, and then this is what happens. And so you can just sort of see how those tiered systems play out. And in this case, as all too often, the one who was uninsured was Black and the one who had private insurance was white. And that was a very stark illustration of me being part of that system and sort of feeling powerless in my own way, but sort of knowing that it was very real. Next slide, please. So what about doctors? So we talk about systems so far and the structures and all that sort of thing, but what about doctors themselves and their interactions with patients, and how does that influence these racial outcomes? This is the former Surgeon General in the 1990s, David Satcher. He wrote this article, kind of similar article in the JAMA in '73. It's really the first thing you can find in the medical literature where someone really looks at it. And it's like a one-page essay. It's really good though. Does race interfere with the doctor-patient relationship? That's his question. I think we know the answer. Let's go to the next slide. This is also from a medical journal around that same era. So this is like 1974. So for those of you who aren't familiar with this little mental health context, so Black people tend to be less likely to be diagnosed with depression or bipolar disorder, and more likely to be diagnosed with schizophrenia, which is a much more severe disorder we think of. It wasn't always that way. That was something that sort of became an outgrowth around the time of the 60s, when you started to see this shift in terms of the diagnoses and the racial sort of differences started to play out. And so this is a medical journal article, medical journal advertisement. Those of you in medicine are familiar with Haldol, which is an antipsychotic medication used for schizophrenia, often used in emergency room settings and things like that nowadays for agitation. But look at the image. This is 1974. You have a picture of a Black man there, and you can see the thing. It says assaultive and belligerent. He's got like a Black power fist kind of thing going on there, and Haldol, cooperation begins with Haldol. So it's this narrative of like control and so what I found historically is that there's a long pattern of African American men more recently, sort of the last 50 years being diagnosed with schizophrenia, much more so than other groups. And what's behind that, right? And so you can sort of see how the bias could seep in, because I'm sure the medical journal at that time, the readership was probably almost exclusively white, as well as the drug company that produced Haldol. And so you can see how that perception then can seep into clinical practice. Next slide, please. And of course, pain and race, which we talked about earlier, this idea of how, and so this is just a reference to that one I referred to earlier from the University of Virginia study. It's certainly worth a look as well. You can move on to the next slide. There's also this is important for all of us, all the medical, it's kind of weird because I can't see you guys, but the medical audience, in terms of people who are actually seeing patients, and what are you doing with that? So this is a really important thing for all of you to think about. So when you're seeing patients, a lot of times I know it might feel like, I've been a resident, I was an intern, I know how you can feel a sense of powerlessness. But if you think about it, there's really tremendous power you have, because a patient comes to you, you have an exchange or a dialogue, and then it's your words that really are the documentation of what happened. And so it's like you're the one that's sort of transposing that person's story through your own interpretation of it into a medical record, which becomes a permanent part of that person's life story. And so the question is, do those words matter? Like what you're putting in the chart? And the question is, they very much do. This is a study this is at Johns Hopkins. It was looking a couple years ago, again, at the world of pain in medicine. And it was particularly looking at the sickle cell anemia population. And what they did is they actually used real medical charts of people who had gone through their emergency room and were described in pretty egregious ways. That's the best way to put it. And they sort of compiled those, and they showed that scenario to one group of doctors, and then they showed them a separate scenario where the same pain complaints were there, but the patient was described in neutral terms, very, very neutral terms. So the terms that were called bias, give you a couple examples. In one, they described a person who was having a sickle cell crisis, probably related to some dehydration, was one of the triggers. And they described the guy as loafing outside of McDonald's all day with his homeboys, and that was like in his medical chart. And it's like, well, like what are you trying to accomplish when you describe someone in that way? Like, what is your purpose? Are you just frustrated that particular time? Are you angry? Are you wanting something to actually happen? So I think that's an interesting thing to think about. So I think that the lesson here is that we have to really think about what are we doing when we talk about people in charts. There's a related discussion about, and maybe we can get into this, about even putting race as the first identifier in a chart. I mean, that's its own conversation. And the trend is getting away from that, but there's still some of that certainly present. This idea of like, age, race, gender as sort of the trinity of how people are described, and what does that lead to potentially? I certainly can recall a case where someone came into an emergency room with chest discomfort. It was like a 40-something-year-old black man, and one of the doctors joked about when did he use drugs last, as soon as he heard the word black. And so you could sort of see how these things can be problematic. No, the question is, can that be a useful thing in terms of a social factor? Absolutely. It's just how do we use it, and what are we trying to accomplish when we describe people in certain ways? I think that's the thing to think about. Next slide, please. And what might be the downstream effects? So all this stuff that I laid out for you certainly can lead to some long-term concerns about bias and mistrust in the healthcare system itself. Here are just 3 books there, and there's many more. Medical Apartheid was very well known. That's looking more at the research side of things, from like slavery to the modern times, looking at racial bias and research. It's much more than just Tuskegee, of course. Black and Blue is another one that very much delves into the history. It's written by a sociologist from University of Texas. Goes very much into the history. So if you really want to deep dive into these subjects, these are 2 good books. The one on the right, how the protest psychosis, talks more about schizophrenia, how schizophrenia became a Black disease. Again, looking at this idea of these topics in the context of the civil rights movement, and how this became like an agent of control, if you will, and so it's really interesting to see. There was actually a study it was a editorial in JAMA or New England Journal back in the late 60s when they were having similar types of protests. In the wave of Dr. King's assassination and things like that. And there was this whole article, and the whole speculation they had was that, well, okay, these protests could be from social unrest, but our theory is actually that it's organic brain dysfunction is the real reason why they're having these protests. So the idea they just sort of swept aside all the historical social context and just said, well, these people just have brain disease. And so again, you can sort of see how this bias can seep in and how they can impact care in very problematic ways. Next slide, please. So before I slip into the idea of looking at the Black doctor's experience, I want to say one more thing. So let's just think about how, because the doctors will say, well, I'm not biased, I'm not prejudiced, or whatever may be the case, but just think about a certain assumption that you might have and how the harm that could come from that. So you see me, I'm a Black person who's a psychiatrist. And in psychiatry, the rates of suicide are lower among African-American people historically compared to white Americans. Now imagine if I then use that and extrapolated that somehow that means that white people have a weaker emotional center or the will or something about them is weaker, and I sort of take that, and then I take that into an exam room and I see a patient. I'm coming with that mindset and I see that person. Now, do you really think that if I have to come with that mindset, that wouldn't impact how they might make a decision about how my evaluation of them? I mean, so I think it's just we have to be really careful. And you have to sort of acknowledge what our problems are, and then how that could be really problematic in a doctor-patient encounter. So that's just one thing I wanted to sort of think through there. So let's switch up gears a little bit here and talk about the being a Black doctor experience, because that's its own set of challenges. I've mostly been laying the groundwork for Black patients and all the struggles that we see with COVID and everything that's led us up to what we see with the disparities with COVID. But what about the experience of being a Black doctor? I characterize it as the good, the bad, and the awkward. Because I think first and foremost, what you see is it's a extension of so basically it's a perception of what do people see when they see you. So when someone sees me, is their first thought, or even second or third thought, that I'm a doctor, right? Typically not. Usually people say, oh, they'll come in and say, oh wow, you're a doctor, and it'll be that sort of look of amazement or just who knows, but very surprised. because typically on a good day, people think of me, and they say, well, I'm probably a former athlete, I'm a really tall guy. I'm well over 6 feet tall. And so that might be a good day. And on a not so good day, it's like, well, this guy's a potential threat or something to be afraid of. And I've certainly had that experience. We don't have time to go into that today of all the things that have happened, including encounters with law enforcement that have kind of been situated on this idea, the premise of me being perceived as a threatening person. So there's all sorts of narratives about that. So I think that's the starting point for a lot of the challenges that Black physicians might receive. Next slide, please. So I talked about some of the the awkward experiences, but there's also been bad experiences in terms of interactions with patients that have been really problematic. There's a story I talk about in the book of a Confederate. Here's some in the background here. I was thinking that was me, but yeah, seeing a patient or a family with sort of Confederate attire is saying they didn't want an N-word doctor. So this was early 2000s when I experienced this. But we would be naive to think that these things aren't still happening. So in the last 4 or 5 years, I've had a chance to travel a lot of different places, and I've heard stories from doctors, medical students, describing all sorts of pretty bad encounters they've had with patients. And there's been starting to be more and more written about this in the last few years. These slides sort of test all the ways in which this sort of patient bias itself can happen to to the residents and doctors. Now, the story I described in the story has a somewhat happy ending in that the family kind of comes to accept me in their own sort of way. But there have been other cases where it wasn't so pleasant, and patients ended up being asked to leave the hospital. Basically, they didn't want to allow, or the clinic, if they didn't want to allow, me or one of my other Black colleagues to see them. So this is a real challenge that is often sort of swept under the rug and not acknowledged to the full extent that it could be. And I think a lot of times doctors, African-American doctors, feel a lot of, and other underrepresented minority groups feel a real sense of alienation and lack of support when these things occur and are not addressed. Most recently, I'll give you a couple examples. A couple students, medical students I talked to recently, described situations where patients said pretty awful things. One would say use a Mexican slur and a slur towards the Asian people, and they told their supervisor about it, and the supervisor was white, just sort of said, okay, don't worry about it, I'll just see the person. And that was the end of the story. But that's really sort of like ignoring the problem, if you will. He may have thought that he was doing them a favor, but that's really problematic. And so and then the other stories I've heard more recently of that sort as well. Let's go to the next slide, please. There's also the dilemma of being, particularly for someone like me, from my social background. I grew up in a 98%, really 100% Black community, sort of lower middle class. And now you're in this world of medicine and you're trying to navigate these two worlds. You're in this world of medicine where there's privilege and hierarchy, but then you're also seeing patients who are part of that other world, the other life. And where do you fit in? So that's a dilemma that not a lot of people navigate. That often there isn't enough space often to talk about and process among Black doctors and trainees. Next slide, please. There's also this piece, we go back to this idea about what's at the heart of racial differences. And some critics will say, well, it's all just about class. It's all just about, these social determinants. It's really just all about money and status. So I think this is an interesting study that kind of makes you think twice about that. So Meharry is a Black medical school, historically Black medical school in Nashville, Tennessee. And up until about 1970, pretty much all Black students, about 90% of Black physicians were educated in Meharry or Howard. Of course, on the right, there's Johns Hopkins, which is in Baltimore. And in the late 50s, these researchers from both universities collaborated, and they followed the trajectory of health among their medical students as they became, residents and doctors and later on in life. And of course, both these schools at the time were almost all men. That's its own separate problem, of course. But what they found was that the Black men, medical students and physicians at Meharry had a much worse health course than their peers at Johns Hopkins. Even though 20 years down the road, they're all, they're anesthesiologists, they're the same specialties, the health outcomes are very different. And so what's behind that? And so it makes you think about all the sort of things that kind of led up to all the different barriers, racial barriers that they may have faced along the way, growing up, but also then even once they still were in the medical field, what those disparities were like. So I think that's just an interesting thing to think about how health is, there is this component of race that is probably independent of strictly the social determinants component. and it's likely related to the discrimination and other factors. Next slide, please. So there's another issue, of course, has been just the fact that there's this real dearth of Black men in medicine in particular. This study came out in 2015, and you can see over a 36-year period from 1970 to 2014, the Black enrollment in medical school among men was basically stagnant. Now, taking into account during that same time, Black women enrollment basically doubled. The Black population increased by 10 million in the US, and the physician population increased by 400,000, which is basically a doubling. So you can see that, so proportionally, the Black men were very much on the periphery in terms of their proportional representation going down. Over the last few years, I've gone to many medical schools where you'll go see a class of 100 students and there's one Black male, 150 students, there's one or two Black men. It's a really common scenario. So when people who are critics of affirmative action, I always kind of smile and think about when people say that there's so many slots are being taken up. I'm like, man, there's one person. And it just sort of makes me smile when people think about how that's this big evil that's sort of taking things over when you see one or two people who are Black men in a class. Just it doesn't comport with the reality that I see. So I think a big part of that is just there's a lot of factors at work. Of course, I think the biggest is just most fundamental is the narrative, what it means to be a Black man in this society and how society defines you. Someone asked about the enrollment for Black women. So the Black women enrollment has doubled during this time. And so I think one of the differences between Black women and Black, I'm not going to pretend to be an expert on Black women per se, but I think among Black men, there is, society has defined Black men in certain pretty narrow ways, whether it's, and again, the issue of perception of threat, or again, on a good day, perception of being a sort of physical athlete. And those are sort of some, unfortunately, those are kind of the ways in which Black men are too often defined by society. And those things seep into you when you're living in that world. Like if you would ask me as a 14-year-old Black man, could I have become a doctor or written a book? Those would have been inconceivable things for me. And I think, why is that? And I think so much of that is about how society has sort of laid things out. Next slide, please. And this is an interesting little thing here. I'm not sure what to make of it, but just take a look at this next slide. So it's a little outdated, you can see, but despite the fact that there's that lower number of Black men in medicine, at any given time, that number still equals the number of Black men who are playing in the NBA or NFL. So when you think about, you see all these images of Black men on television in sports. Again, I'm not I love sports. I played basketball in college. But I think it's an interesting kind of contrast, right? That even despite that, there's still as many Black men in medical school, despite the problems, and these numbers are way low. There's still that much more of a better opportunity to sort of succeed in this field, just one field, medicine versus football or basketball. Now those photos are outdated because LeBron is now playing with the Lakers, and I guess Cam Newton just signed with New England Patriots. So those are outdated photos, but I think you guys get the point. Just something that's kind of food for thought. Next slide, please. So looking at the demographic data, so Black people comprise about 13% of the population, 4% of physicians. So you can see the pretty significant contrast. And where that plays out is that, next slide, we'll kind of show a little bit that further, how the problems with that. So many of these urban areas where African American patients are in large, proportion, are also places where many medical schools and teaching hospitals are located. So Durham, where Duke is pretty comparable with Chicago, where we're running that kind of between 35-40% African American rate. Even New York and Boston, which are still on the lowest end of this group, are still twice the national average. So you have this pattern of people being educated and trained in these settings that have large Black populations, but a very few Black providers. So in my own training program, I was the only Black psychiatrist for a portion of it, for one of two, pretty much the whole time. And that one outpatient year in clinic, we had a patient clinic that was 45-50% Black. I was one Black provider out of like 10 to 12 people. And that first week, I had like twice as many, 5-10 times as many more patients as they did. So I'm just starting out like everyone else, but there was this sort of pressure to sort of serve that greater need. And that's just sort of a reflection of the larger problem. Next slide, please. I want to make sure I leave some time for questions here. So Black doctors and Black patients. So this is a study that came out in 2018 looking at, is there anything to that? This idea that if you have a Black male doctor, you're a Black male patient, does that matter in terms of your utilization of preventative medicine? So this is looking basically where Black men more likely to get diabetes screening, cholesterol screenings, weight screenings, blood pressure checks, and they were more likely to get that when they were seeing a Black physician. Why is that? I mean, Is it trust? Is it relating to the person? There's probably a lot of factors at work. It's hard to generalize on any individual encounter to the larger group, but I'm sure that for any individual person, it could be some combination of all those things that were taking place for sure. Next slide, please. And we have more time, we can talk more about that. So how do we move forward? I think this is important in the moment that we're in. I think and this quote is also really instructive for where we are right now, not only in a larger society, but also within medicine. This is a quote from Dr. King in the Birmingham jail, the letter from the Birmingham jail, where he said, "First, I must confess that over the past few years, I have been gravely disappointed with the white moderate, who prefers a negative peace, which is the absence of tension, from a positive peace, which is the presence of justice." So let's think about that for now, for where we are. So it seems like prior to, when we think about the protest that we're seeing now, it seems like prior to May 26th, which I guess when George Floyd was killed, there was a lot of that preferring the negative piece, absence of tension. Like maybe there's a problem, but I don't know, I don't want to see it, I don't want to think about it, versus the positive piece of how do we reckon with our history. Medicine, I feel, is in some ways guilty of that same sort of negative piece. We know there's a doctor who's saying something problematic. Oh, that's just the way he is. Or we know a patient says something problematic to a student, racist to a student. Oh no, it's okay, don't worry about it. You don't have to see that patient, I'll just take care of it. So that's sort of avoiding the tension, but then not really addressing the larger problem. And I think for far too long, society is engaged in that problem, and very much medicine has been complicit in that in so many ways, and it's harmed both patients as well as trainees, students and trainees for many years. Next slide, please. So how we move forward, of course, this one of these word clouds that sort of talks about all the factors at work. We certainly know all these things that are at work, the social deterrents of health. So it's not just the idea of like, I mean, there's legal components, there's public health components. I think there's the idea of conceiving medicine as not just the encounter between a doctor and a patient in an exam room or a hospital, but that it occurs in this much broader societal context. So I think that's where we are, and we have to, whether that means in medicine, we have to partner with other people, which we will, in order to address these problems. I think all that's so very true. Next slide, please. Couple examples here, just these are a few things. So about moving forward, so Reach Equity is the research arm at Duke, and so how do we do sort of real constructive research? Because there's a lot of stuff describing these disparities, but what are we trying to do about them, and what works and what doesn't? I would say there's been sort of this passive sort of, we know it's a problem, but we're not really going to invest the resources to sort of look at some of the solutions. And so this is one research arm, like in a systematic sort of way. So Reach Equity is something that's taking place at Duke. Other places, and that's just a new initiative, fairly new. Other places are doing other things. I think the whole point is that we really have to get into the research aspects of it. And then to do that, we have to address why do maybe Black people are less likely to engage in research studies to begin with. We have to address that ugly history. There's a lot of things we have to really go through, but the research arm is really important. The thing on the top right, NC Care, is actually an organization that's like a wraparound organization, just started last year, where it's looking like if you see someone in a clinic and you refer them to a community resource, what happens? That happens all the time. Well, you need to go see this person, but then we don't know if the person goes or what happens if they went. This is like a system where they're trying to wrap that care around, where if I make a referral to a community resource, a food bank or whatever may be the case, I then get the feedback that that person went there and this is what happened and this is the plan. Now, why it took till 2019 for that to happen, again, that just speaks to this idea of this sort of passivity in terms of how addressing these larger problems. And these things themselves are just small pieces to the puzzle, but these are the things that have to happen. The bottom left is just looking at 3 generations of Black women and just how do we have to address these issues from birth to death. Like these things impact everyone, so it impacts all physicians, all people who are working in all different areas of medicine, whether you're a pediatrician, whether you're a geriatrician, general, primary care, adult internist, the whole realm. You have to really sort of be attuned to these issues at each stage of life. And then on the right there is just the bottom right, is a quote about, if you never tell anyone what you expect, then expect to be disappointed. I think that's a lot of what's happened for a long time. But this younger generation of students I'm seeing are really speaking out a lot more, saying, no, we don't, this is not acceptable. These things that we've let go for so long are just not there. And they should not be there. So I think it's just about this. We need to set the groundwork, but we can't expect people to be responsible unless we sort of find ways that make them accountable in a real tangible and measurable sort of way. Next slide, please. I think this might be the last one. And then finally, just the larger story is how do we change this long-standing narrative of what it means to be Black. in America. Now, again, I'm focused on Black men because I'm a Black male, but I know that many of the Black women have had these very same experiences about how Black women themselves are confined and constrained. And we have to sort of redefine and take back the way in which society has defined us and take ownership of that and sort of reconfigure our native, sort of our own destiny. So I think that's really what I'm looking at with that last image there. And then final slide. I think this is the final slide. Then is going back to what do you as doctors and patients do? Because the world we live in, of course, is not one where every Black patient. I'm not advocating for segregated medicine. First of all, I'm just going to say that because I think that it stifles the opportunity for tremendous growth that people can have. I do think people should have more choice. For some people, that may be really important in certain aspects of their care, and they should have that opportunity. And so that's something that speaks to the idea of creating more of a cadre of African-American providers, of course. But we also have to work on the idea of how do we treat people who are different than us? How do we integrate with them? How do we learn from them? How do we see them as not just a problem or someone to sort of get in and out? And how do we see them in the context in which they exist, but also understand how they might perceive us. So it's like a two-way relationship. It's not just about our own bias, but it's also about how does a patient receiving us based on their own history, and being attuned to all of that is all really important as well. So I think as we move forward, we have to continue to interrogate our own beliefs, and as we move forward, and think about how they could be harmful and what could we do better. Just more recently, people are asking me, how do you talk to a patient about race if you're a white person? I've heard this a lot now. So I think the first thing is just even having that conversation be open on the table. For far too long, people would just want to avoid it. Again, it's that negative, that absence of the negative piece, if you will. Let's just not talk about it. Let's not go there. But just sort of opening it up and sort of saying, how do you feel about this particular thing, or has this been something that's concerned you, or have you thought about? And then just opening up that patients up to have that space to talk about it. And that first time, they may not want to say anything. They still might feel comfortable. But the idea that you open it up as a possible, that's something that's open for debate or open for discussion in the exam room, may make them more likely to come back the next time and then talk to you about it. So those are the kind of ways. And again, it may not go perfect. You have to realize, a lot of encounters we have with patients don't go perfectly. It's not just about race. It's many things that cannot go perfectly, but just to be open to that possibility and that vulnerability, I think can be really valuable for your patients and for yourself in terms of your own growth as an individual. So that's all I have. I know I took up a lot of time, but hopefully there's time for some questions.
Thank you, Dr. Tweedy. Yes, we have several questions. The first question, I'm going to let him speak. Dr. Olu Ajulor, you have a question?
Yes, thank you for a really great talk. One of the questions I have is that as a Black psychiatrist, sometimes I have difficulty separating racist attitudes of my patients from their psychiatric issues, like, for example, if they have paranoid ideation. So I was wondering if this has happened with you, and what are some of the ways you use to sort of distinguish the two issues, whether they're having racist attitudes or whether it's related to their underlying psychopathology. Thanks.
That's a great question. Like, so are you trying to get to the idea, is racism a mental illness? Are you going that direction so much?
Not, really? not quite.
That's its own. That's its own can of worms. We don't want to go there today.
Yeah.
And I'd say no to that. But as far as the piece about sorting this out, yeah, that can be a real challenge, particularly when you're dealing with patients who are kind of have more broad delusions. And so the question is like, how much of that do you take personal,
right,
or is this part of their own sort of illness, sort of, and that's a difficult challenge. I had a student have that issue actually one time with a white supervisor. And this is what you don't do. So the white supervisor just said, "Oh, it's no big deal. It's just their mental illness. Just basically go back and talk to that person." And then the students just sort of just trying to express their discomfort with it. And the supervisor never acknowledged why the student would feel discomfort. They said, "Well, this person just has psychosis. Why is it bothering you?" And so that is definitely the wrong approach to it. I think you have to sort of be able to separate. You have to be able to kind of understand these two things can be going on, but that both need their own attention, right? And so you have to be able to really understand that this, even if that is their delusional thing making it worse, it doesn't mean that it's still not something that needs its own attention and conversation and be addressed. Because the patient still might need a redirection and say, well, this is not something you can say at this particular time, or whatever may be the case, right? And the supervisor needs to be able to recognize why that still could be harmful to that trainee to hear that.
All right, our next question is from Shirley Scott.
Yes, when you had mentioned about the attending, just kind of breezing over the medical students' concern in reference to not the patients not wanting to have them take care of them. What would be your expectation of how the attending should have handled that?
I think it depends on the situation, right? So you have to talk about whether, like, is it an emergency room where it's a life and death sort of thing, or is it a routine outpatient clinic encounter? I think, or is it something in between? I think that's one part of it. I think one way in which they need to address is they need to just, at some point, just acknowledge to this. There's two things. One is acknowledging, having conversation with the student about it and how they're feeling about it. Because in one particular instance, this one student was from another country, and they didn't really grasp the sort of racial dynamics in this country, and they were just crying. And because they couldn't understand why, what was happening. And so for them to just ignore that and to never even have a conversation about that to the student, I think it's a lost opportunity. The student might just feel alienated and say, so then I asked the students, had they ever told anyone about it? And they said, no, well, if my attending acted that way, why would I expect anyone else to be different? So they never told anyone what had happened. And that's a real loss for that person. So I would say that's one thing. As far as addressing with the patient, I think it depends. I think there's cases where the patient, there has to be some boundaries. I don't think a patient can just be free to just, just use slurs without any sort of, I don't think that. I think there needs to be some boundaries set there as well. Whether it could be saying, oh no, this person, like for instance, if I'm supervising a female doctor, I bet people say, well, try and undermine her. Oh, she's a good, try and undermine her in some way. I say, no, she's this is a great medical student and she's really smart, and try and sort of build her up versus sort of, trying to allow that person to sort of bring them down. So I think it's important. I think that's something that's a missed opportunity if we just sort of just avoid it.
Our next question is from Samin Hassar.
Yes, hi. Thank you for the talk, Dr. Tweedy. I just have worked with a lot of pre-med students, and there's a lot of this attitude around, especially with people who have very high educations, and it's this idea that Black people have an easier time to getting into medical school because they can get away with lower MCAT scores. And I was wondering if you had any thoughts on educating and like sort of confronting those ideas. Would really appreciate it.
Yeah, it's a great question. So, I mean, I think there's a lot of different factors there at work. Again, if that were the case, again, if you look at the numbers, then you wouldn't have like so tiny few Black people in medical school if everything was just so easy for people to kind of go through that path. I would say that the scores themselves, this is as someone who's learned to become a really good test taker. So over the years, I kind of learned the game, but I think that the idea that itself is a measure of being a good doctor is really problematic. So for instance, I grew up in a community where I was told that, test taking, I was told by instructors, you can't study for your SAT, or, and I had so little access to the capital that people have who are taking these prep courses and stuff. And so my first 4 rounds, I did really poorly. But then once I figured out how to do it, my scores like skyrocketed. So that just shows to me, that shows the limitations of what these tests are they're really showing. And so I'm really, so I would say two things. I would say one is that you're not accounting for all the barriers that are in place that make it more difficult for people to have access to the materials, like prep courses and all that stuff. Because I mean, because if those things didn't work, people wouldn't be paying and taking those courses. They clearly help. And so there's lack of access to that, which is a huge factor. And then just the numbers don't bear it out that Black people are just getting in and taking over American medical education. There's nowhere does that the numbers bear that out. I mean, I go to schools and there's 1 or 2 Black students out of 100. So I mean, it's like this idea that it's easier, it just doesn't comport with the reality of what you see on the ground at all. So I would say those are the 2 things that sort of stand out.
And then I think we have time for one more question. Sally Campbell-Lee. Is she not on? Okay, we have another question. I'm going to, oh, sorry. Okay, Sally.
Oh, hi.
Yes.
Yeah, hey, I'm faculty here in pathology department. Dr. Tweedy, it's nice to meet you. Real quick, just strategies for when your abilities are doubted, not by patients, but by students or trainees. I've had the situation here happen where I gave a lecture, and at the end of the lecture, I had a student come up at the end and ask me, was I really a doctor?
Wow. Yeah, so certainly I've had those kinds of experiences as well. And you said in pathology, so like basic sciences, I mean, that's just one of those areas where you just see even fewer, underrepresented minority faculty and women faculty as well. Yeah, I would say I probably would say, yeah, I'm a doctor, every bit the same as that whoever person came before or after. I might be tempted to tell that student that, or in some days I might say, well, I might wonder why you asked that. Like, so sometimes I'll turn it back on them in a way by trying to do it as gently as I could. Was it something what I said that made you curious? And so, and just sort of see what the response is, because that might be an opportunity for them to sort of realize, ooh, yikes, or whether that person's malicious or not. I mean, sometimes I'll turn it back on that person, but in a gentle way, with the intent of making it clear that I understand that what they said was problematic. So that's one of my strategies as well. That's my normal strategy.
And actually, my co-chair, Dr. Minju, has one last question for us. I know we're at the top of the hour, everyone, so.
This will be, hopefully, I had a question that was going to require a long answer, so I'm going to put that aside for later. I had a question for you about evaluations. I know that evaluations overall could negatively impact underrepresented minorities because they tend to get poor evaluations from students and trainees. It could also be so from their supervisors and so forth. And so how do you balance that with actually combating and speaking against implicit and explicit bias within your work environment?
Yeah, I think people have to take a real deep dive into like talking to the clerkship directors or the course directors. These things happen for real. I mean, I've had it happen to me personally where if I didn't go out to some golf outing, I never played golf before in my life. I didn't go to this golf outing with this medical team because I thought I was going to make a fool of myself, right? And so, but their response was then to put that on my evaluation that I was aloof and antisocial or something so these kind of code words kind of come into play and then it can impact you. So I think, really, I think you have to have the person who's doing those, like in some cases, I think even at the medical school level itself, the people who are reviewing those evaluations have to be willing to, or have the power and to sort of be empowered to sort of challenge and question what is happening at the root of these evaluations. I think for far too long, people have passively allowed those things to happen to the detriment. Because what I've seen is that a lot of times Black students will either, and other minority students will either be described as too quiet or too aggressive. I've seen the same thing with women as well. There's sort of like you get this paradox: either you don't participate at all, or if you do, then you're too loud and you're obnoxious or whatever. And so I think we have to just confront people and sort of faculty. I think the faculty need training. The people who are doing these evaluations, they need systematic training themselves. We can't just train our students. We have to go back and train these faculty as well and find ways to hold them accountable if they're doing things that are problematic, within that. So I think this has to really be a institution-wide approach to it, not just to these people. That everyone has to really be involved for the progress to occur.
All right. Well, thank you, Dr. Tweedy, for spending the past hour with us and answering all our questions and giving us so much insight for us to think about here at our university and institution as well. Oh,
yeah, the final thing I'll say is I think people have to, this has to be something that's larger than it can't be completed in an hour discussion, right? I mean, first of all, I talked too long. I wish I had left more time for questions, but secondly, this is something that's a much larger conversation. It has to continue to happen at all levels of the institution for change to really happen. You can't just say, well, I came and talked and that's it. It's got to be, this should just be the beginning of you guys then sort of talking further about what are we looking at? What can we do differently? What are our students saying? What are they saying? What are our residents saying? And what have we done wrong? What can we do better? I think those are the things we have to sort of have that kind of approach for us to really move forward and make progress.
Yes, and we have been doing that here. We're doing our homework right now on the medical student level, and the residency level as well, and faculty level. And I actually would love to connect with you offline to see what is being done at Duke University. Maybe there could be some collaborations.
Yeah, I'd love to hear what you guys do in more detail.
Yeah.
So thank you.
All right. Yes. Thank you so much.
It's a pleasure.
All right. Bye.
Take care. Bye-bye.
Bye.